Just going to get in the mindset. I mean, you can edit all this stuff out.
Of course. Okay. Hello there. My name is Vic Beard. This is Jim Roberts, my anaesthetist, and we work together every Wednesday. And today, what we want to talk about is these masks, face masks, and we just want to talk about the design of these things. And actually, Jim knows much more about this than I do, so I'm just going to pass him over. You talk about it.
Okay. So this is a face mask. You can see here this shape. It's like a cone with a little pneumatic seal, which is meant to seal around the nose and mouth. If I can use Vic as a model. And that provides an airtight seal so that we're able, through this attachment here, to give the necessary anaesthetic gases and vapors to keep Vic asleep and oxygenated. This little device here is a filter, just to make sure that there's no exchange of heat and moisture, and to keep everything clean. And the shape of this mask is really important. When I was training, we used black anaesthetic masks, which had a much more anatomically contoured shape. And one of the things we'd like to do is address that issue, or the fit of this mask, to fit patient facial shapes better, because we find that there are some challenges with this design. One of which could be sizing. So the masks come in various sizes, and if you choose, or if your face falls between two sizes, it's quite easy if Vic just turns towards the camera and we get this out of the way, excuse me. I don't know if you can see the nostrils, but if I bring this mask down, pretending it was a smaller size, it can actually occlude the nostrils. And often anaesthetists trying to lift up the jaw to bring the tongue and open up the airway inside, if they're not using a special oral tube we sometimes use, by shutting the mouth as you're trying to bring the jaw up, and by squeezing on the nostrils, you can get into a situation where you can't face mask ventilate, and that's really bad, because you really want to be able to give oxygen and anaesthesia to a patient.
So what you're saying is that, so you're asleep like this, mouth is closed, because that's what this mask is meant to do. It's meant to pump air through the nose.
It and the mouth, but if the operator is lifting the jaw up
Like that. Okay.
to open the internal airway, you can often end up shutting the mouth unintentionally.
But then you're saying this presses on the nose.
And if the mask is too small, or if it doesn't fit your nasal shape well, it can end up squishing the soft bit of your nose closed. So you can end up in a situation where you've just blocked the patient's mouth and nose. Partly because the shape of this mask doesn't encompass.
We're just doing a YouTube video. It's okay.
That's okay.
Just give us a second.
No worries. We'll just edit back.
Yeah.
So the actual shape of the mask can end up unintentionally contributing towards nasal obstruction and mouth obstruction, which means you're not in control of the patient's airway. So
you're saying to me also that. It's you now. Should I just press it?
Oh no, it's somebody else.
Oh.
Yeah.
Okay, so what you're also saying at one point that because this is completely flat, you said something about anatomical shape.
Yes.
And the previous mask was sort of shaped around your face. This one, I guess, is cheaper than.
Exactly, that older design. And I think you can see here that there is a degree, it's not perfectly inflated, but there's a degree of scalloping, but essentially this mask is flat with a pneumatic cushion. You can, through this port, control the amount of air and therefore the pressure in the pneumatic cushion, so that it seals better with the patient's face. But the fundamental truth here is that this is flat, and of course your own face, you can imagine, is not flat. It's got shape to it. And the older masks were much more aggressively contoured and scalloped to meet that anatomical variation. And I think from my memory of training, they were a lot easier to hold on. So one variation technique we sometimes have to do is to pinch the sides of the mask together like this. And that produces a little bit more depth. So if we just take care of the veer nose by pinching this together, it gives a little bit more depth to the mask. And that means that the quality of the seals kind of improved.
You're right, it hurts just there.
But
This
it- but
bit
it-
there hurts.
That's So there's not enough cushion here. We could inflate it a little bit more, but even then, there's still not enough cushion to encompass Vic's nasal shape.
I've seen you before when you're trying to get air into something and it's sort of leaking, a bit like a CPAP mask. People have problems with CPAP masks. You're trying to pump, that hurts. You're trying to pump air in and you don't want it to leak out the side. You have to press quite hard, and I can see how that would hurt.
Exactly, and we have these are all hacks that we do, and another hack is to use the heels of both hands,
do it
like
on
a
me.
two-hand technique, is to push using the heels of your, or even the thinner eminences of your thumb, the bases of your thumb, just to push both sides of the mask and even produce a little bit of squidging as well to get that necessary seal. And in that case, because you're using your two hands to get the mask to seal on the patient, you're going to have to be reliant on your assistant to squeeze the bag. So we call that a two-handed technique. We can also use a hack where the mask goes on, there's a bit of leak, and sometimes we bring the cheek onto the cushion of the mask to augment the seal. Sometimes, in extreme examples, we
Just
sometimes
using my fat just to
just using exactly. Sometimes, especially Vic, he's a great subject. Actually, put some Tegaderm over the beard, and
Like a
that
plastic
helps.
sticky stuff.
Yes, that's just like a see-through plastic sticky medical grade tape, and that just helps interface with this material on the cuff as well.
Oh, I get. So you're saying that the air sort of goes because of my beard, it doesn't get a tight
Yeah,
seal.
it doesn't get a tight seal, exactly. So what we're saying is that as what commonly happens, we're given a piece of apparatus that for good reasons is effective and maybe cost effective, but might be improved. And we think that there are some improvements that we can make to this system, which will mean that the seal is improved, the shape is better suited, maybe through 3D facial scanning to get a common facial pattern, which would support a more anatomical design. And given the fact that the face mask is the absolutely core tool in anaesthesia to oxygenate a patient, we think this is something that's worth investing some time and innovative energy in.
So a lot of people, as far as I know nothing about anaesthesia, so this is why I'm asking. But I've seen you use this at the start of an anaesthetic,
Correct.
and then you normally put the tube down.
Yes.
But I've seen people use this when, say, someone's got a big tumour in their neck, and you're trying to get air past them, but you just can't get that tube in because there's just not enough room. And some of my patients with obstructive sleep apnea, they've got big tonsils in the way, and the side of their throat's collapsing in, the tongue's falling back. You end up doing this quite a lot to get air in, make it safe as possible.
Correct. Yeah.
But if this isn't sealing properly, presumably it's not. It's a bit like CPAP. You're trying to pump air in, but it's not really working in some cases.
Yeah.
And what we're trying to do is maybe there's a better design for this, so we don't get into that situation.
Correct. Exactly right.
And so you were talking about how the nose doesn't fit. Well, particularly my nose, but I guess other people's noses might fit. So if I had more of a flatter nose rather than this big enormous honker, but the problem with flatter noses perhaps is that you're saying that if you press it just there, you sort of block your nose completely.
You can end up, so often with young pediatric patients or with people who do have flatter noses, if the sizing or the application of the mask in terms of position is not ideal, you can end up squashing the nares, squashing the nostrils closed. And that leads to that problem I was explaining at the beginning, where you, through the best intentions, you're trying to lift the jaw to open up the internal airway, but you've unintentionally closed the mouth and you're squashing the nostrils, you end up with an obstructed airway. And that's, that can lead to an anaesthetic emergency.
So say you're in that situation where you've got a sort of blockage, like one of my patients with sleep apnea, they have problems breathing when they're asleep. When you give them an anaesthetic, they're going to have twice as many problems.
Mm-hmm.
We use that to try and keep things going so you can have another go.
Correct.
But if that's not working, what would you end up having to do? Would you need to do?
We may do. So there is an anaesthetic set of circumstances we call can't intubate, can't oxygenate, CICO. And what that means is that the anaesthetist is unable to support the airway with a face mask to administer oxygen, and is also unable to pass that metal L-shaped instrument, the laryngoscope, into the mouth to be able to pass a tube, and they can't do that either. So they've essentially lost control of the airway. They've rendered somebody unconscious, apneic, not breathing. They can't reproduce their breathing for them. The oxygen is being consumed by the body and not being replenished by the anaesthetist. Their saturations will begin to fall. This is an anesthetic, life-threatening emergency. And in some cases, doing a surgical incision into the cricothyroid membrane just in the front of the neck to enable the passage of a tube into the windpipe.
Yeah. So you've got your Adam's apple here, and just below the Adam's apple there's a window there that you can stick a knife in, basically, and make a hole. So instead of getting through all the tonsils and the tongue falling back, you could just make a hole right through there and then stick a tube in there rather than through your mouth or through your nose. But obviously, we don't want to do that to people. And if this worked better, we wouldn't feel stressed that might happen to some people. So that's why I think the design of this has to be really important. It probably works for, 95% of people? Or...
Exactly. I mean, it's just an example of something that's adequate, but it could be done better and probably for a cheaper price. And it just seems silly that, given it's such a core anaesthetic, basic piece of apparatus,
like I'm about to
give you an anesthetic, that we think that there's a design opportunity here to improve it.
So because the NHS, we don't have huge amounts of money, what we're thinking of doing, and what we want to do is let you join in this journey of ours. We've got a whole bunch of ideas, to make this better. We're going to do a bit of research first, and I'll talk about in the next video about these face masks. And then we're going to design a new face mask. The challenge is to make it as cheap as this so that other people will be interested. And if it works better and it's just as expensive, just as cheap as this version, then I'm hoping people will look at it and go, yes, this is great. And what do you think? That sounds like a plan.
Yeah, absolutely. I mean, I think now it's so easy to scan faces to gain knowledge and to inform design. It just seems silly not to use that technology. It's so easily done.
I think we're going to stop now, aren't we?
I think we should.
See you later.